This must be a beauty.
So let's talk about the bowel in review just a little bit. I know you've already had anatomy 1 at least, and most of you have already had anatomy 2, but this may have been a while back. So just to review, we've got small bowel, which is also called the ileum, and we've got the large bowel. The small bowel is about 23 feet in length, so it's really packed in there. Coming through, we have, so the stomach, and then we've got the duodenum right here, which is the first part after the stomach, and we've got the jejunum, then it turns into 23 feet of ileum. The small bowel comes into the large bowel right down here at the bottom. That's called the terminal ileum, meaning the terminal end of the ileum. So that will stop right there. What is the job of the small bowel? I heard something over here. I heard absorb. Absorb what? Nutrients. So the small bowel's job is to absorb nutrients from the food that we eat. And minerals, not water. So all of what goes through the small bowel is going to be liquidy in consistency. So if a person had surgery and removed their large bowel and all they had was their small bowel, and they bring it out right here in the abdomen, right down here, and create an ileostomy and put a bag over it, what would it look like? What goes in the bag? All liquid, that's exactly right. And if it's to absorb nutrients and break down the food so that it can absorb those nutrients, what if some of that spillage got onto the skin around the ostomy site? What would happen to the skin? It would become very irritated and begin to break down, because that's what's in the stuff that's coming through the small bowel. All those enzymes in there that break down the food so that it can be absorbed. Yes, that would be very caustic to the skin around the stoma. And that's why we have to make sure that we clean around the stomas very, very well when we're doing ostomy care. So it comes out and dumps right here into the large intestine at the terminal ileum. That little section of the large intestine is called the cecum, and this would be the appendix right down here. That's all in the lower right side of the belly. So this whole part of the colon is called the ascending colon, because everything ascends up it. The transverse colon goes across the belly, and then this is the descending colon, because everything is coming down. This is the sigmoid colon, the last part of the colon right there before it dumps into the rectum. So there is smooth muscle all over your intestines. And the smooth muscle contracts in it's called peristalsis, and contracts in waves to move food through the bowels, all the way through. So if we have general anesthesia, which kind of paralyzes everything in the body, you can see how those smooth muscles will not work, and so peristalsis does not occur, and so nothing moves through the bowel. So when a person comes back from surgery, we have to listen, auscultate, to make sure that we hear bowel sounds when their bowel is starting to wake up. Once we hear bowel sounds and they can begin to pass flatus or gas, then we know the gut is working well enough to start feeding them food after surgery. Now, what is the function of the large bowel? The large bowel is about 5 feet long in most adults, from beginning to end. The large bowel's job is to say it again, John.
Make it solid.
And so it absorbs the liquid, because remember, the small bowel has nothing but liquid. and jumps into the large bowel, then you gotta do something with all that liquid to make a solid food, right? So the large bowel's job is to absorb the water and make a solid food. Okay? So, things to remember about that. The longer the stool stays in the colon, which is the large intestine, the longer the stool stays there, the drier it's going to become, and the harder it's going to become. So if a person has been 5 days since they've had a bowel movement, when that bowel movement finally comes, it's going to be hard and dry and hard to get out because it's sat in there for so long, all that water's been absorbed out of that. So we don't like for people to go that long without having a bowel movement. That's one of the things, we talk a lot about bowel and bladder in the hospital all the time. We have to ask all those personal questions. So we say, like I said earlier, if it's been more than 3 days, then we can officially say the person is constipated. I think your book says the definition of constipation is to have fewer than 3 bowel movements in a week. And that makes sense because if you go every 3 days, you know, that's 1, 2, 3 days, 1, 2, 3 days, and then you're at the 7th day, and you should be working on another one. So if you have had less than 3 in a week, you're probably constipated. Okay? So things that influence bowel elimination. Your age influences bowel elimination because we just learned that children are not neurologically developed enough until 2 or 3 years of age to even begin potty training. And we also know that bowel training usually occurs later than urinary. They get the urinary continence down pat pretty good. It may take a few more months before they get the bowel continence under wraps. So your age has a lot to do with it. Your diet has a lot to do with it. If you eat a caffeinated product, what's that gonna do? It's gonna make you go to the bathroom, right? Drinking coffee, does that make you want to go to the bathroom? Chewing gum, eating prunes, all these things can make you have a bowel movement. So your diet has something to do with it. If you eat a lot of bran products that have a lot of fiber in them, what's it gonna do to your bowel? It's gonna put more bulk into your diet and make your stools firmer and theoretically help you obtain that bowel movement that you're looking for. But if you eat the fiber, what must you do with that to prevent constipation? Drink a lot of water. They go together, always go together, to help moisten that fiber and get it moving through the gut. So fluid intake is a big deal. If you don't drink the proper amount of fluid, you're going to be dehydrated. That's just the way it is. And when you get dehydrated, your stools are going to become constipated. It just works that way. Physical activity. If you get up and get moving, it helps stimulate peristalsis to occur. That's why surgical patients, we make them get up and start walking. It helps get their bowel to wake up and gets things moving again and helps prevent constipation. So very important, physical activity. Psychological factors can influence your bowel elimination. If you're on test day, you know, think about what your stomach is doing. It's like churning. It's like you've been to the bathroom, you know you don't have to go, but you feel like you need to go to the bathroom. Bless their hearts, I've had students to get ready to do their checkoff, and you're standing at the bedside getting ready to do it, and they just look at me with tears and go, I gotta go to the bathroom, and they just run out of the room because their stomach is just churning because they need to go to the bathroom. That's fear. Y'all don't be afraid of checkoffs. Don't be afraid of checkoffs. We give you 3 chances to pass everything that you do, so you'll have time to pass it. Personal habits. Positioning. What's the best positioning for having bowel movements?
With your feet elevated.
Sitting or squatting, actually, squatting. So now they have those stools that are called squatty potties. Have you seen those advertised? Stools that you can put under your feet so that your knees are up kind of high like that. That squatting position is the way to be. Pain in pregnancy can affect whether you have a bowel movement. Do you want to go have a bowel movement if it hurts to do it? You kind of keep it sucked up in there, right? Because you don't want it to hurt. If you've had a baby and everything hurts down there, the last thing you want to do is get constipated, because then you really pay for it. Anesthesia, surgery, medications. What medications am I probably thinking about right now? Laxatives. Laxatives, 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 and we'll talk about those. They make you go, go, go. So lots of things influence your bowel elimination. So constipation and impaction. Constipation is defined as going longer than 3 days to produce a sufficient stool. Most people normally go 1 to 3 days. Sometimes they might go more than once a day. Sometimes they might not go but once every 3 days. Whatever is normal for that person. Impaction is a different word. Impaction means when the stool is older than 3 days, it's dry, it's hard, and it's causing problems and great discomfort. That is called an impacted stool. Now, to get rid of an impaction, there are things that we can do. We can give people an enema to help moisten that dry, hard stool. And we can give them prunes and coffee. I actually had a patient that wanted me to pour their prune juice into their hot coffee and stir it up together, and that's what he wanted to drink. Warm apple juice, warm any kind of anything. Fruit juices are wonderful, prune juice and apple juice, even warm water. I had a friend one time, and she drank a cup of warm water, just warm tap water, every night before she went to bed. That was her routine. But warm things help get things moving. Another thing that we do for an impaction is to do a digital removal of the impaction. So that means putting on a glove, lubricating your finger, and you gotta go up in there and get it and pull it out. And we got a slide about that. You're gonna read about how to do that. You have to have an order to do that. And that could cause problems for the patient, so we don't treat it very lightly. One of the complications is digging around in somebody's rectum could cause them to have a Valsalva reaction, which means they might do what? Faint, right? We just talked about that. Makes them feel syncopal, makes them faint. It can slow down their heart rate, slow down their blood pressure, and they can pass out. So it's not something we just go in there and go have at it. You know, we treat it very gently, professionally, get it done. If we see the patient is having a problem with it, we stop. Okay, no need to keep digging around if they're gonna pass out trying to do it. So we'll talk more about that in just a minute. So some of the problems with constipation are talked about on page 325. If you look on page 325, there's a table 5.7 that talks about selected causes of constipation. You might want to put a star beside this little table. Impaction is unrelieved constipation on page 271 in your skills book. You will learn the instructions about how to digitally remove stool. So you'll have to go to your stool skills book to read about that, okay? I'm leaving you to it. Bowel incontinence is just what it sounds like. You leak stool. Results from things that impair anal sphincter function. So you've got an internal anal sphincter and an external anal sphincter, and those keep everything nice and tight down there so nothing falls out of your rectum. But if something impairs those two sphincters, then guess what? Whatever's in your rectum might tend to fall out. And it tends to be worse if a person has more liquidy stools, because liquid stools are harder to hold in than solid stool. And so I've got two little stars beside that. So down on my notes page, I've got two little stars that give you some examples of things that can impair the anal sphincters, such as gynecological procedures like episiotomies and childbirth, prostate procedures, rectal surgery, nerve muscle damage from trauma or radiation, hemorrhoids even, and rectal prolapse when the rectum starts falling out and you have to push it back up in there. So all of those things can impair sphincter continence. And then on my notes page a little bit further down, it's got talking about bowel incontinence, things that make it worse. Alcohol and caffeine can make bowel incontinence worse because it makes you have to go to the bathroom and have a bowel movement. So if you're troubled with incontinence already, then take that stuff out of your diet. Certain people develop diarrhea after eating dairy foods because they are dairy incontinent. That can be a problem. If you already have bowel incontinence, why do something that's going to make you have diarrhea and make it even worse? So what we can do for people who have incontinence, as it says here, is add bulk to their diet. That means adding fiber. So bran products add fiber to the diet. There are medications like Metamucil that is a high fiber product and it adds bulk to whatever you eat. And the fiber works like a sponge and can help soak up some of that water so that you're not having such a watery stool. So Metamucil is actually, even though it's classified as a laxative, we give it to people who have diarrhea to help absorb some of that water so they don't have diarrhea as often, and it helps with urinary incontinence. So here go the laxatives, and they're talked about on page 327 and 328 in your book. So just a quick rundown. We've got the bulk forming laxatives that we just talked about that add fiber to the stool. Examples would be FiberCon, that's easy to remember. Anything with fiber is going to be a bulk laxative. Metamucil is the one that we use the most often in the hospital. We mix it with juice and the patient drinks it. So the thing to remember about bulk laxatives is the patient must also drink lots of water if they're going to take a bulk laxative. Osmotic laxatives like milk of magnesia, which is milk of magnesia, or fleet cinemas, those are osmotic laxatives. They work by pulling lots of water into the bowel. And if you pull lots of water into the large intestine, it's going to push everything in it out. And if you've ever taken milk of magnesia, you take it and you stay home, right? You don't go anywhere because it's going to make you into your colon. Stimulant laxatives are even worse because they stimulate the intestinal peristalsis. So they actually get the muscles to start squeezing around that colon and push everything out. So stimulant laxatives are even stronger than osmotics. Stimulant laxatives can cause cramping and abdominal pain because they create that strong peristaltic movement. So examples of those are like bisacodyl or Dulcolax. Then we have stool softeners like Colace. And Colace is something we give in the hospital all the time. It's great, it's very gentle. It's considered a laxative, but it's really not a laxative. All it really does is pull a little bit of water from the body into the fecal mass itself and soften the fecal mass so that it's nice and soft and squishy and easy to pass through the colon and to get out. So stool softeners like Colace are really good for people who don't need to strain to have a bowel movement. such as people who have had rectal surgery. Like if you've had an episiotomy that cuts everything in your perineum down there, you'll probably be given Colace so that your stools are nice and soft and easy to pass. If you've had hemorrhoid surgery, you'll probably be given Colace for the same reason, just makes everything soft and easy to go. If you've had a heart attack, and you don't need to strain to have a bowel movement because that can damage a tender heart. Yes, people have actually, I know two of my friends that actually were straining to have a bowel movement and passed away on the toilet. Two of my friends, they were in their 30s, both of them. They had a heart condition, but it was a mild heart condition, but they both passed away on the toilet. And I've also had a patient that did the same thing. He got up, he had come in for an MI, he had recovered, he was, and he got up to use the bathroom and strained to have bowel movement, and he died right there. Did not see it. So straining is something you don't want to do if you have a heart attack. So we give all those heart patients Colace every day to help keep their stools nice and soft. Stool lubricants are things that do just like what it says. They lubricate the fecal mass and make them slick, and they'll slide right through the colon and right out. So things like mineral oil just slicks things up, right? You have to drink it. Castor oil has a flavor. Mineral oil really doesn't have much flavor. You can get it kind of flavorless, and so it's easier to get down. Something to remember about stool lubricants. If a patient has trouble swallowing, like maybe a stroke patient, and they tend to get choked a lot when they swallow because things go down the wrong way and they end up with water in their lungs, they should not drink mineral oil or castor oil, because if they get choked on that and they get oil down in their lung, it can cause a very deadly pneumonia. So that was great music to go with that. So people who have trouble swallowing don't need to drink lubricants because they can get an oil-based pneumonia, and that's pretty deadly. And then we have herbal agents like Senna or Senna-Cot. Herbal agents, a lot of elderly people take Senna because it helps them to have a bowel movement, but they can be problematic in themselves. They can be, cause a lot of discomfort and cramping and stimulation because they're like stimulant agents. So they're not the easiest to tolerate, but older people really love them because it makes them have a bowel movement. And what do you know about older people and their bowels?
They want to talk about
Fixating on their bowels, like every day, they gotta have one. And it's problems for them, and they have a genuine complaint because the sensation to have a bowel movement decreases with age. So they don't feel the urge like we do, and they may drink less because they don't want to go urinate as often, so they tend to be more dehydrated than we are, and the two together just make a recipe for disaster. And so they really do struggle to have a bowel movement, and so they really do kind of get fixated on their bowels and want to have bowel movement every day, and that's okay. We can give them Metamucil and it'll be fine. So laxatives, please read pages 233, 27, and 28, and read your notes pages for your laxative information. So this is what happens if you don't clean someone's body effectively after they have bowel movement. This is a baby, and that skin is gone. It is a raw body on this baby. He had been in a diaper with stool, and his parents had not changed the diaper, and he sat in that stool. And it was a liquid stool because this baby had been given Senna, and he had a liquid bowel movement and had all that caustic, those enzymes that come with a liquid stool, and he sat in it, and it ate his skin away. And this is skin breakdown from that neglect. I can't even imagine how bad that hurts. So, hygiene needs. Keep the area clean down there. All that down there, keep clean. If they have a Foley catheter, you have to do catheter care once a shift, especially if they are incontinent of bowel, because you don't need that bowel movement sitting right there where that catheter is, because those germs go right up the tube into the bladder. So keep them clean. We use barrier products on the bottom, right? Barrier creams. After we clean the skin, then we can apply barrier cream and help protect that skin from breakdown. Now, enemas and suppositories in your skills book, yes ma'am.
For barrier cream, as CNAs, are they allowed to place, because is that technically a medication or does it vary?
They do not consider a barrier cream a medication. Now if it's a medicated cream, like, nystatin, you know, that's a medication that you've got to scan, and it's a medication.
Right.
But a regular barrier cream is not considered a medication, so NAs can do that. Yes. So skills book, page 267 to 270 talks about how to administer enemas. Again, you'll get that in your lab about how to administer a suds enema, how to administer a Fleets enema. Never give an enema with cold water. If you put cold water in someone's intestines, what's it gonna do? What is it gonna be comfortable for the patient or not? It's gonna cause a lot of discomfort and cramping. And so we don't use hot water either, but we use warm water for enemas. Warm water. Never force the insertion of a tubing when you're giving an enema. You have to place the tubing into the rectum. Of course, you lubricate the tubing, and you put the tubing in, but never force it. If you run into something, you don't know what it is. You think, oh, that's a compact, it's a impaction, that's a hard stool. No, it could be a cancer. It could be a swollen rectum. You don't know because it's a blind stick. So never force the tubing. Only put it in for the amount of that you need to put it in for. If you can't get it that far, then don't force it. Always use lubricant, of course. And so we'll show you in the lab how to do this, okay? But read about it in your book, page 267 to 270, before you go to lab. So again, this is a page where I had, didn't used to have my notes pages available for you, but now you got all the answers down on the notes page. So for this. So for a bowel training program, or some people call it a bowel retraining program, is what we can do for patients to teach them how to get back on track with having their normal bowel movements. So these would be people who have had bowel surgery, perhaps, and, you know, or have, so I had a patient a couple of weeks ago in clinical, and they had rectal surgery. And in order for the rectum to heal, they had to divert his colon out through the stomach, and he had to have a temporary ostomy so that the rectum could heal. It can't heal if he keeps having stools through it. So they gave him a temporary colonoscopy to allow the passage of the stool to be diverted long enough for the rectum to heal for the next few weeks. So when that rectum is healed, they'll go back in and reconnect everything, take away that ostomy, reconnect everything so he can have normal bowel movements again. That patient will need to go through a bowel retraining program to get his bowel to work right again. So these are things that we do. We set up a daily routine for that patient. It requires consistency. So think about when you go to have a bowel movement. The the time of day that your gastrocolonic reflex is the strongest, gastrocolonic reflexes, the strongest time of day is in the morning when you get up or right after breakfast. That's just when most people have to go to the bathroom and have bowel movement. So we'll start the training there. Get them up every morning, get them on the toilet, get them in the habit, right? And that will help prompt things to start going again. Provide privacy, use behavioral interventions such as sitting on the toilet after every meal. We can give them stool softeners or maybe insert a suppository to stimulate the onset of a bowel movement to help get that bowel retrained to start moving again. We can give them a fluid of choice to stimulate a BM. Most people want coffee, hot coffee, or prune juice that helps stimulate bowel movement. Teach the patient to sit on the toilet and lean forward. That's kind of like a squatting position, and to use like a stool under their feet so their knees are up and they're leaning forward in that squatting position, and that helps them to evacuate their bowels a little easier. Provide encouragement and support and get them to drink, and I've got on here at least 2,500 milliliters a day. That's 2.5 liters. That's extra fluid. That's good. The more fluid they take in, the easier it is for them to have a bowel movement. So bowel retraining is discussed on page 336. On page 337, there's a whole section on patient teaching. Again, you need to read this. Now, also on pages 334 to 337, at the end of every chapter in your book, you've got a section that says nursing process. It takes you through the nursing process. So what are the steps of the nursing process? I think I'll have that. That's the first step. Assessment. There you go. So it takes you through all of those steps of the nursing process relating to the information in that chapter. What things to include in your assessment for someone who has a bowel problem. What planning do you need to do for someone with a bowel problem? What interventions would you provide, or how would you implement care? And then how would you evaluate whether your care was effective? So you need to read that section. Always read your nursing process section, the whole time you're in nursing school. Now, GI assessment, you've had assessment already. I think Ms. Tate taught y'all assessment a couple of weeks ago, right? And you learned about doing a GI assessment. You know, we have quadrants, the right upper quadrant, left upper, left lower, right lower, and how to do a proper GI assessment. So I'm not gonna go over that here. You've already learned that. I do need to tell you about a couple of other things. One of them is this test that we do to look for blood in the stool. So this is called a fecal occult blood test. Occult means hidden. So sometimes people have a bowel movement and there's blood in it, but we can't see the blood because it's occult, it's hidden. So we do a fecal occult blood test, and that will show up whether or not there's blood in the stool. It's a non-invasive test. We just take a sample of their feces on a stick, and we have this little card, and you'll see this in lab because we have the examples of it in the lab. And you smear a little bit of their stool on the card, and you close it up and turn the card over and open up a little window in the back, and we have special drops, and you drop a drop on the card, shut the window, wait however many seconds the card tells you to wait, then you open up that window and look, and if it's blue, then that means they have blood in their stool. So this is what the blue looks like. This is an example of a positive fecal occult blood test. And you would report this in your documentation, and you would tell the doctor or the provider that he's got a positive fecal occult blood test. So you'll learn how to do this in the lab. On the notes page that goes with this slide, you'll see down at the bottom, there are some things that patients should avoid if they are going to be doing home fecal occult blood tests. So when you get to be a certain age, and you start having to have colonoscopies and that kind of thing, when you're around 50, the doctor may send you home with a little package of 3 of these fecal occult blood tests to do at home. One every day for 3 days in a row. So not 3 on one stool that you have, but 3 separate days. And if you don't have a stool on the second day, fine, wait until whenever you have a stool. But 1 stool one day, 1 stool on another day, 1 stool on another day. 3 fecal occult blood tests, and you'll do it at home, so you'll have to teach your patients how to do that. As it says on my notes page, if they're gonna be doing home tests, they should not eat red meat during the time that they're testing. For about 3 days before the test, you should avoid certain fruits and vegetables, including broccoli and turnips. You should avoid red meat. You should avoid vitamin C supplements. And then you should avoid pain relievers such as aspirin, ibuprofen. Why should you avoid aspirin? Because it might make you bleed, and then you would have a false positive test. I mean, it wouldn't be really false, because there could be blood in your stool, but it could be because you've been taking aspirin and not because you have a colon cancer. So what this is looking for, so the doctor would probably ask them to stop that for 3 days before the test and then resume it when they finish. Because what they're looking for is reasons to make somebody have blood in their stool, such as colon cancer. So this isn't going to say if it's positive, that doesn't mean they have colon cancer, but it could. So you wouldn't tell your patient, oh, it's positive, you have cancer. You just say, it's positive, this means you have blood in your stool, and we need to investigate why. Is it a tumor up in there? Is it a hemorrhoid that's causing a problem? Or did they take aspirin when they were taking the tests? Or did they eat broccoli and turnips? You know? So there could be all kinds of reasons, but the reason we're really doing it is we're testing for bad things, okay? They can cause you to have blood in your stool, just enough that it can make a positive test. Yes, yes. And so you would just, so if it was positive and I told my patient it was a positive result, and they say, what's that mean? All we can say is it means there's some blood in your stool. That's where we go with it. We don't get into the rest of the details. They know as well as we do what can cause blood in the stools. And we inform the doctor, and then the doctor will order more tests. Now, there's another test that you may have to do as a nurse for people who come in with chronic diarrhea, and it might be because they have parasites or worms. I've actually had patients with worms, and we have to test the stool for ova and parasites. And this particular parasite that you're looking at is yardiasis. It just causes chronic diarrhea. So we just take a collection of stool and send it to the lab, and they'll test it for ova and parasites. So when you do a stool sample, what you do is you collect it in a container, and we have to label the container with the patient's name, room number, medical record number, a patient sticker that's got all of their information. And we also have to put our initials and time and date on that label. Now that we have the computer systems, some computer systems, you put that information in the computer and it prints out a label with that on it. If it's not one of those special systems that does that, and you just have a regular patient label, like in a nursing home, sometimes you just have a regular patient label, then you have to write your time, date, and initials for the time that you collected that specimen. And we put it in a biohazard bag, put the container in a biohazard bag, seal up the bag, and send it to the lab. We don't let it sit around on the counter, we go ahead and take it to the lab. So that's for all stool specimens. So this is the last part here, and we're gonna talk about tubes. And you'll do this in the lab, you'll learn how to put down an NG tube or a nasogastric tube. So the nasogastric tube that we typically put down to drain someone's stomach with is called a Salem sump tube. Y'all know what a sump pump is?
Yeah.
You put a sump pump under your house to suck up all the water under your house. It puts it out in a tube and takes it out to the yard, right? That's a sump pump. So this is a sump tube. We put it down, it goes through the nose, down the esophagus, and into the stomach, and then we put the other end of the tube to suction, and it suctions out the stomach. So this is a Salem sump tube. There's a blue part to the tube, you see that blue, that arrow pointing to the blue port? That whole blue piece is an air vent. So, think about this. If you, have you noticed on your cups that you have a little hole in them that makes an air vent? If you stop up that air vent and try to suck up on this straw, you're not gonna be able to get anything up that straw. You have to have the air hole in your cup to let air in to break that vacuum so you can suck your water out of your cup. Same thing with the Salem sump tube. The air vent is there so that the suction device can actually suction up out of the stomach. If we didn't have that air vent and we put the suction on, that whole stomach would just go right around that tube and suck up around that tube. But the air port lets the stomach stay distended so that the tube can just suction everything out and the stomach won't collapse. So that's good. So we don't ever want to clamp the air tube or the air port. We always leave it open to air. And that keeps the stomach from collapsing. And so we put the Salem sump in. It is not a sterile procedure because it goes in the patient's nose and the nose is not sterile. So we put it in the nose, goes all the way down the esophagus into the stomach. We secure it to the nose with tape, and we hook it to suction. So the Salem sump tube should not be used for feeding, even though patients, you'll see some patients being fed tube feeding through this tube. It's really a stiff tube, it's hard and stiff and not comfortable. And if the patient needs a feeding tube, we have a special feeding tube that we can use that's real soft and pliable and much easier to tolerate being down the throat that we should use for feeding. But you'll see patients come in, get a Salem sump tube put in to drain their stomach for a few days, and then the doctor says, discontinue suction and start feeding. And the nurse just removes the suction and hooks the tube up to a feeding bag and feeds the patient. So you'll see that. It's not preferable, but you will see it. This is somebody who has a tube in him. We use it to decompress the stomach after surgery and to remove whatever's in the stomach. We use it to relieve nausea and prevent aspiration. We can use it to deliver medications down it, or we can deliver food down it. And you can see in this one, what's coming out of it looks like blood. It's dark. That looks like blood coming out of that. So if anyone that comes in with a GI bleed is going to get an NG tube, and that's how we're going to get the blood out of their stomach. NG tubes do not require sterile technique because it's just a clean procedure, not sterile. It is uncomfortable to put down for both the patient and the nurse. But you will learn how to do it in the lab, okay? Once they're down, you have to assess the patient and tube every 4 hours. document what's coming out of the tube, how much is coming out of the tube, how well the patient is tolerating it. And part of the assessment is going to be flushing the tube. So you'll flush it with like 15 milliliters of tap water every 4 hours to make sure it doesn't get clogged up. And so part of your output for that patient is going to be what comes out of that tube. So it drains into a bucket, suction canister. So tell me, if you have a patient that has had an NG tube for 8 hours, and so you flushed it with 30 cc's of water when you put it down, you flushed it at 4 hours and you flushed it at 8 hours, how much flush have you put in?
90 milliliters.
You put in 90 milliliters of flush, which is tap water. What's in the suction canister is 110 milliliters of fluid. How much output has the patient had?
20.
Right, because you don't count the flush that you put in, that's what you put in. What the patient put out of his own body is the rest of it. So you would subtract the amount of flush from the amount of what's in the canister to get your amount of output for that patient. So in clinical, if you have a patient with an NG tube, you would go to that canister in the morning and notice how much is in that canister at 7 o'clock that morning. When you leave at 12 o'clock for lunch, you notice how much is in that canister, and that's how much your patient has put out while you were in clinical. And you would take however much flush you put in and subtract it from that total amount, and then that would be your amount of output for that patient. Does that make sense? So when you're in clinical and you have that, your instructor will be with you, help you go through that, help you flush the tube, and help you, manage the output, and so that you can document that in the patient's record. I'm not putting that on the test for you right now, that's a clinical thing, but that's something you might see in clinical practice.
Can I bring up one thing? It's so important to listen to where the tube is. We've had a few patients that it was put down the lungs, and that's where they were putting everything.
Yes.
And it makes them very sick, so it's just important to listen.
Right, and I didn't go over that because that's something you're gonna go over in lab. But yes, when you're putting down an NG tube, it's a blind stick, right? We train you how to put it down, but when it goes down, you hope it's going, there's tricks to make sure that it goes in the right place. And you're hoping you're getting it in that right place, and when you get it in the right place, it's gonna be in the stomach, right? So she's saying, listen with a stethoscope to assess placement. So you would take air in your syringe, put like 30 cc's of air down the tube, it's gonna make a gurgle sound. When you're listening with your stethoscope, you can hear that, and you'll say, okay, it's in the right place. If you don't hear that, then chances are you put it down the trachea and it's in the patient's lung instead, and you wouldn't want that. You have to take it out and put it back down again until you get it in the right place. So now we're gonna talk about, and I didn't go through it because we're gonna talk about it in lab, but we're gonna talk about it now. The listening to it is not the preferred method for assessing placement, because you can listen incorrectly, you could hear referred sound, it's really curled up right here and not in their stomach, but when you're listening, you hear the referred sound and it sounds like it's in the right place, but it's not. So what we typically do is either we do a pH test to determine if it's in the right place. If it's in the stomach and we do a pH test, is it gonna be acidic or alkaline on that test strip?
Acidic.
Correct. If it's base, where is the tube likely at? In the lung. So we're looking for an acidic test to confirm that it's in the stomach. A lot of places don't have pH test strips for gastric content because they're very expensive. So what we typically do in the hospitals now is after you put an NG tube down, you send the patient to x-ray.
Oh, okay.
Yeah, so there is, a white line that goes all the way down the tube that's an opaque strip that shows up on x-ray. So the protocol is you put a tube down and you send them to x-ray to confirm placement. But you'll learn about all that in the lab, okay? Good. So here you can see that white line. See this white line coming down the tube? That is that opaque strip that goes all the way down the length of that tube. And that's what would show up in x-ray. This guy's got blood coming from his NG tube. This child has a feeding tube going through the nose, down the esophagus to the stomach. And that's a feeding tube. And it's nice and soft and rubbery and little compared to how big this tube is. That NG tube is about the size of my finger. It's big and stiff and not comfortable. But this little baby has a little feeding tube. And they're measuring marks. Can you see the little black all the way down that tube? Those are in centimeters to know how far down the tube is. So if you put the tube in the patient and at the nose right here, you notice that it's at 30 centimeters and it's in the right place and it's taped and secured, and you come back 4 hours later and it's now reading at 40 centimeters or 20, you know the tube has slipped out of place and it's migrated out of place. And what would you do?
Put your butt down.
So one, you would not use it until two, you put it right back in the place where it's supposed to be, right? So you look for that tube migration by looking at the measurements on the tube and seeing if it's at the place where you last saw it. This is an example of a gastric tube that's placed in the stomach. It's surgically placed. We don't put those down as nurses. The doctor surgically puts them in and sews them into the patient, and it can drain. And so you'll see gastric tubes sometimes in patients coming from surgery, and they're meant for drainage. This is a PEG tube that we use for feeding. You see these a lot in the nursing home. Patients that can no longer swallow because maybe they've had a stroke and they get choked every time they try to swallow, but they're still alive. So we gotta do something. We gotta feed them. So they'll put in a PEG that stands for percutaneous endoscopic gastrostomy tube. And it's just a short little tube. They put it right through the skin into the stomach and blow up a balloon on the other end so that it can't pull back out to the stomach. And then they hook that tube up to feeding and they feed the patient through this tube. So that's a PEG tube. This is an ostomy. So this is for a patient who has had the ostomy that you see here is way down here on the belly, lower right quadrant. So this patient has had his colon removed or her colon removed. And what's being pulled out through the skin of the stomach now is the end of the ileum, which is the small intestine. So they took the whole colon out, the whole 5 feet of colon is gone. They took the end of the small intestine and pulled it out through the stomach and sewn it there so it won't go back in. And they're gonna have to wear a bag, an ostomy pouch over that, and their stool now comes out through that ostomy. So things to remember about ostomies are, a new ostomy is going to be beefy red in color. I've got beefy red on the PowerPoint, just like you see in this picture. Like hamburger, like beefy red. That's a new ostomy. An older ostomy that's well healed may not be beefy red anymore. It may look pink, like the inside of your mouth, that kind of pink. That's normal, it's nice and pink, it's getting good perfusion, that's good. Blue is not good. If you see an ostomy that looks blue or black, what does that mean? That part has died. There's no oxygen that got to it and the ostomy has died. and now it's necrotic, and they're gonna have to go in and cut it off and redo the ostomy. So we don't want to see blue or black, we want to see beefy red in a new one, or nice and healthy and moist and pink and rosy pink in an established ostomy. An ileostomy is going to be where the ileum is pulled out. That's gonna be on the right side, and an ileostomy is going to produce liquid stool, because liquid is what's in the ileum. A colostomy is where they take part of the colon and remove it, and bring the rest of the colon out through the stomach wall, and make a colostomy. So that can be anywhere along the length of the colon. You could have this part of the colon removed, so your ostomy would be here. You could have this much of the colon removed, and so your ostomy would be, or you could have this much removed, your ostomy would be here. Here, look, they have all of their colon until right here. The rest of this is gonna be removed, so they pull the colon out right here, it's on the left side of his belly, and made of stoma, which is another word for an ostomy. Stoma. So it can be anywhere along the path of the bowel, and that just means part of the bowel has been removed, and now the stool will come out through the ostomy, or that stoma. Stoma means opening. Stool will now come out of the ostomy instead of the rectum. And so the patient will have a bag that they wear over it. And in lab, you will have a mannequin that has ostomies on it, and you will learn how to put on the ostomy bag, how to stick it on and apply it, how to change it, how to clean it. You'll get all of that in lab. Sometimes it's temporary, like the patient I had at the hospital with the my clinical group. As soon as his rectum heals, they'll reverse his colostomy, sew that back up, take his intestine and reconnect it to his rectum, and he'll be normal. So sometimes it's temporary. Okay, it's 11 o'clock. I had an activity, but it's too late to do it, so we're not gonna do it today. When you're studying this, remember to read everything, but pay particular attention to those page numbers I gave you. If you have any questions, let me know before the next test. When is the next